Good morning, friends, and thank you, Professor Arun, for involving me in this interesting instruction course. We are talking on some diagnostic tools which are at higher platforms because may not be accessible to common people here. But why should we talk in such a way to propagate instrument like this, equipment like this, which talks about higher order aberrations in cataract surgery? Because we all know cataract surgery now has become a refractive cataract surgery. So you have to acquire devices, tools which can give you a more precision in terms of selection of patients, in terms of giving a good intra-op results and managing post-op problems of these patients also. So which are those devices going to give all these things also? Toric intraocular lenses is part of a cataract surgery. You can't say toric is a premium IOL nowadays. It is a part of a cataract surgery. In fact, almost 50 to 60% of cases would require a toric IOL implantation. If you take one diopter as a cutoff, around 30 to 40%. If you take cutoff as a 0.75, then almost 60% of patient would require a toric IOLs. Now with the trifocal lenses, EDOF lenses, the acceptance of a toric is less than one diopter. Even I have patient with a zero point 0.5, zero point 0.6 also. They may require a toric implantation because that's going to improve your quality of vision for your patient. So the toric IOL is one of the important gametes of cataract surgery. We talked about eye trace system, which gives you all three things. It gives you a pre-op analysis of your patient. It can help you in an intra-op assessment also. And most effectively, it gives you a post-op analysis of your patient in a very, very precise manner. I can understand a large number of toric IOL patients may not require a rotation, may not require an assessment because the quality of outcome is always better with the toric lenses. But if you're using a trifocal lenses, yes, there you may have to look for all these areas. We talked about corneal curvature power, angle alpha, the aberrations by which you can, look into your patient. In fact, iTrace was one of the initial devices with us which gave us some sort of correction of your toric markings, which was not available earlier because we acquired iTrace very very early. Then subsequently we had image guided devices coming subsequently also. So this is a very important. You have seen this slide many many times, which separates the internal aberration from the corneal aberrations, and then you can plan accordingly these patients. And angle alpha, Dr. Rajesh highlighted all these points. Inbuilt toric calculators may be there, which can help you in terms of identifying the axis of your implantation. It corrects your implantation axis. It can be your power also if you feed your biometry readings in those areas. So these are two important areas which may be helpful for your patients for getting absolute intra-operative collection also. So what we do normally is to mark physically first with a bubble marker. You can see this by physical marker. Then subsequently take the patient to eye trace again to see if your markings are correct or not, how much deviation from the initial marking you have, and it gives you a new axis of implantation for your patient. And that you know that you are 10 degree, 5 degree away from the initial physical marking. Accordingly, you can place your marking also. So these are two important pre-op areas which you can assess for your patient and subsequently look for these areas. So I have talked about two important areas. One is looking for a corneal profile, separating the aberration profile from the total internal aberration profile. So those patients where your corneal profile is good, so these are patients you are going to succeed in giving good outcome for your patient. Patient may have only corneal toricity. So you can do a very nice toric IOL and good implantation and good results. But there are patients you don't, if you do have younger patient where you can do refraction also. So you have a refraction showing a two diopter cylinder, but if you see the cornea doesn't have a cylinder, that means the lens is compensating there. So you have to be careful in those younger patients. But most cataract patients don't have that dilemma because you can correct very. The other important area for toric implantation is the post-op alignment check. I'm saying check because every patient may not require a rotation, but you have to do check for all your patients. So around less than in my series, it's less than a 1% patient may require rotation sometimes, especially the trifocal lenses. So if you have more than 10-degree rotation, vision less than 6.9, patient not happy with your outcome, then you may require a rotation also. So various lenses are available. People are reported how much rotation these lenses have in a post-op period. It all depends what type of design you're using. So these are open loop L-shaped haptic lenses, which is supposed to be more stable in the back compared to those plate haptic lenses, which may have a more rotation, especially silicone lens in your patient. 1 week post-op may be the good time for a re-rotation in these patients. There are various ways to look into your patient in a post-op toric implantation and how to judge how much rotation is required, how much correction you'll achieve is the important part for your evaluation for your toric patient. Classically, we do a cylinder assessment for these patients. You can do retroillumination photographs, and these photographs and your axis and refraction can be taken in online software, which is www.astigmatisfix.com, where you can get the ultimate outcome. But if you have iTrace with you, you don't have to go in all these areas. Just take the patient to iTrace. It can give you enhancement software. It tells you all the profile also. So all patient needs to be dilated. Before that, you see the uncorrected visual acuity. Perform refraction, see the refractive cylinder error, dilate the pupil, and determine the new IOL axis. If you have these reading, then you can do all these areas. But if you don't have these devices, don't worry. You know that which patient is going to achieve correction after rotation. So this is the sort of a general formula for your patient. Will rotation help in this patient or not? If your spherical equivalent is more than cylindrical error, rotation may not help because spherical error is much more here. So that may be a actual error in your calculation. You see here minus 2.5 spherical and spherical equivalent 2 diopter, the cylinder is less. But if you have a patient where cylindrical error is more than spherical equivalent, rotation might help in these cases. You can see 0.5 spherical with 0.5, 1.5 cylinder. The effective is spherical over 0.5. So this is a patient where you may succeed in these cases. So you can see this is the example here again. -1 spherical and 3 diopter cylinder, and the keratometry cylinder 2 diopters, corneal plane 1 diopter. You can see this patient may not achieve any help by rotation in these patients. So that you have to understand which patient might help in your rotation also. So this is the estimatedfis.com where you can reassess the new axis, the old axis, the amount of power required, and feed that and tells you which is the new axis for your IOL, how much rotation is required, how much correction you'll achieve. So same thing can be achieved in iTrace without any of these helps. So this is what iTrace we have done after toric implantation. You can see it says that 26-degree rotation may be required for this patient, which will correct 1.56 diopters and refractive error will decrease significantly. So this is a patient we may have to rotate where visual acuity may not be better than 6.9 for these patients. So this is the same patient where it tells you that this is the alignment of your patient interoperably. This is a new actual axis. So this lens requires a rotation by 27 degrees, but you can't rotate reverse these J loop lenses. L-shaped, you have to rotate entire 154 degree to achieve this correction. So this is another patient, 74-degree rotation. So this normally doesn't happen in your series because even any surgery, you may not make so much a mistake. It may be 10, 15 degrees. So this is a patient, high myopic patient with a large bag. And this is a one-day post-op results. I waited for at least 2 weeks for this patient, then took the patient to rotation. By the time bag will, little get fibrous, you have a more uh, manageable bag and rotate the lens subsequently also. This is my very simple technique for these patients. This is the patient where we implanted the wrong axis because of improper disclosure by the assistant, and I implanted a different axis here. So this rotation, this is a 48 hours after surgery. You can just go the irrigation on, and with your cannula, you can just separate a little addition, maybe then optic haptic junction. Once the bag is open, with the irrigation on, you can just rotate. You don't require a viscoelastic also. So this is when you have a larger than 10-degree rotation. If you're less than 10-degree rotation, people are doing in office also by needle. People have described, which we don't advise for people in India as such. It's always better to take the patient to operation theater, do a comfortable preparation for your patient because it's again an intraocular surgery for these patients. So this is the patient, 1-degree rotation after I did a re-rotation and no change, zero cylinder now. So this is what analysis with iTrace gives you a satisfaction that you have done a correct assessment and a correct achievement for your patient. So this is one patient shows 25-degree rotation. But this rotation, if you I do only 0.5 diopter change, that means this is a patient maybe had a more spherical power than the cylinder. So therefore, I may not do any assessment for this patient in terms of rotation. May require a different type of correction for these patients. So this is a patient requires 0-degree rotation and change. But if you see into a visual quality was, it was poor visual quality because of a ocular surface problems for this patient. The aberration are much more in these cases. It's not only the rotation of a case, it is you have to look for aberrations also for your patients, ocular surface for your patient before you go for rotation for these cases. So this is our comparative study we did for a manual versus image-guided implantation of toric IOL. Use of eye trace gave us the idea looking to the quality of vision for these patients because rotation from the main axis was less than 5 degree in both the groups. But the quality of vision, which we assessed by eye trace in terms of MTF and Stulls ratio, was much better with the image guided systems. So eye trace gives you that assessment for your patient in these areas. The optimization can be done preoperatively by assessing angle alpha, higher order aberrations, calculation of toric IOL power, intraop, gel lever caliper might help you in getting a proper access. Most importantly, the post-op analysis of the eye trace gives an assessment of our toric IOL implantation as such. I do for every patient who undergone toric IOL. May have a 6/6 vision also, I still do a toric assessment for these patients and see how much the residual refraction then needed, toric rotation by enhancement software, and takes you through the right way to assess for these patients. So eye trace is really helpful for enhancing your cataract surgery, refractive cataract surgery practice, especially for a newer generation lenses, which requires a absolutely precise outcome for your patient. Thank you for your kind listening.